So thank you very much for inviting me to this webinar and to do this, Glenn. I'm sorry, I just missed the last part of the introduction. So apologies if you've already been introduced, Gilbert, but I'm just going to introduce you again as the Fellowship Programs Operation Manager, and Gilbert's going to be working in the chat box nice and hard to answer all of your comments and questions as you have them on this program. I did, before my internet dropped out, I did hear Glenn saying that I was at the helm of this new program. I must say that I'm not solely at the pointy end of this project. There are many of us in the college who are trying to get this program off the ground. I'm only one of a wonderful team headed by Gilbert. So I'd just like to start by acknowledging the traditional owners of the land and sea on which we live and work. I'm currently in Melbourne at the RACGP office on the land of the Wiradjuri people, and I'd just like to welcome any Indigenous people who might be here today and pay my respect to elders past, present and emerging. So this evening's webinar addressing a number of questions which Glenn and others has raised of being probably most of interest to those that are supervisors from GPSA. So you can see the list of questions on the screen at the moment. These were also the questions that were advertised in the flyer. So we're just going to work our way through those. We're going to stop intermittently to get Gilbert to add anything extra to what's been said and to highlight any questions in the chat box. If you have, please do ask questions. We really want to hear what you're thinking and what you'd like to know. So without further ado, we're just going to launch a couple of polls just to get a bit of a feel for the audience that are with us tonight. So if I get, Glenn, if you can launch the first poll, and it's just looking at the current best description of your current situation. Excellent. So we've got a range. We've got basically about almost a third of people are in metro, regional and rural remote. So we've got a good spread, and we've got a couple of practice managers as well. Excellent. So we'll just go on to the next poll, please, Glenn. Excellent. So not surprisingly, we have a large number of people who are currently GP supervisors of either AGPT and or RVTS registrars. We've got a few people who are on limited registration, of those who are supervising international medical graduates on limited registration, and we've got some MEs from RTOs, and a few people are interested in thinking, what is this about? Maybe you're interested in having a participant from the PEP program in your practice. Excellent, thank you. So moving back to the slides now. So just a bit of an overview of what the Practice Experience Program, which we call PEP, is. So this is a program that's aimed at non-vacation registered doctors who are not in the AGPT. So that's the Australian General Practice Training. So those are your current garden variety registrars, those that are working towards fellowship outside of that pathway. And there are two programs that are equivalent. There's one that ACRIM are running. So ACRIM's program is a variation of the Independent Pathway program, which has been run successfully for some time and now is attracting some government funding. The RACGP has not had the equivalent independent pathway in the past. We've had a program that was a pilot looking at giving some support to practitioners studying towards their exams outside AGPT. That was a very small pilot a couple of years ago, and that's helped inform the program that is now being rolled out as a co-funded program from the Department of Health in conjunction with us. So what we're looking at doing is we're trying to partner this program, a true partnership between the RTOs and RVTS and the RACGP. So with AGPT, it's run by the RTOs essentially, and we're overseeing as far as standards, etc. go. In this program, we are working in more of a combination partnership, so sharing the roles and responsibilities of looking after the participants, selection, monitoring their progress, etc. So it's not a training program in the way that AGPT is. It's more targeted education support. It's individualised, looking at the doctor's own learning needs, and very much on a self-directed learning type vein. The program length does vary depending on the doctor's needs, so it's between 6 months and 18 months in duration. The first cohort, who are just started this year, I've got either a 12-month or 18-month program. The 6-month program is likely to be limited to those that are coming in under a specialist pathway. So that part of the program is not up and running yet, but in due course, those that have qualifications in general practice overseas but need some acclimatisation, so to speak, to the general practice environment in Australia will be joining a shorter version of the PEP program. So one of the important take-home points is that although this is completely optional at the moment, by 2022, it's going to be compulsory that if you want to sit RACGP exams, you're needed to do an education program. So this is either the PEP program or the AGPT program. So we're no longer going to allow people that have no training or no education or no support just come in and sit exams. So that's where we're headed with this program, though I'm sure the program's going to look quite different by 2022. The current program is phase 1, and we're going to use the lessons learned in phase 1 to continue to improve and move on and make this program the most appropriate and the most efficient and most effective that we can. So where does it come as far as funding goes? Well, this is actually part of the Stronger Rural Health Strategy. So it is essentially a rural workforce program. It comes under Section 3GA of the legislation. So these, apologies, I'm going to use a couple of acronyms here. The most important things as far as numbers and legislation goes is there's a 19AA and a 19AB parts of the health legislation. The 19AB, also known as the 10-year moratorium, affects those that were trained overseas, essentially, or those that were not permanent residents when they started medical school. So those international medical students come under 19AB as well. 19AA affects everyone that was not grandfathered as in 1996. So essentially anyone since that time. It basically says that the only way of getting Medicare rebates is either through joining a 3/8 GPA program. Inclusive of that is things like the AGPT program, the PEP was a workforce program, as is things like after hours deputising, things like the Rural Locum Relief Program, the SAP program. So all these are 3GA programs that allow any post-1996 doctors to be able to get Medicare rebates while they're working towards their fellowship. And the practice experience program, it's actually called the Fellowship Pathway Program as far as the actual 3GA name of it goes, but that's now an official RACGP 3GA program, the first one that the RACGP has ever had, and that's came into effect as of the January this year. In the first intake, we have a maximum of 400 people coming in. We're currently looking at around 200 active participants, and we're going to have a second intake looking at moving up to 400, which is the cap that we've been given by the government for the first year of operation. It is a co-funded program, and that means there's government funding, but there is a participant contribution, which is currently $2,000 per term. So to be able to sit this program, they need to pay that money per term. So term is a 6-month term. So if they have a 12-month program, it's going to cost them $4,000 overall, and $6,000 if it's an 18-month term. So the funding is much, much less than AGPT, like a whole level of magnitude different to AGPT. So there is government funding available, but it's not the kind of support that registrars get in the AGPT program. Now, an important thing about where this fits into the whole scheme of things, and that's just a quick word about exam capping. So in the past, there were no caps on exam attempts. So essentially it meant that if you failed your exams, you could sit and sit and sit and sit indefinitely, as long as you were still registered to practice in Australia and you met the other eligibility requirements such as general practice time. Now, for those that are used to the AGPT program, registrars, people thought, oh, you could only really sit 3 times and then you were out. Well, you weren't actually out of sitting the college exams, you were just out of the AGPT program. So there are many ex-registrars that got Medicare numbers other ways or worked in the hospital system but could continue to sit exams. Now, when we look at the results of the people that have sit and sat up to sometimes, well, an enormous number of times, they didn't do very well, and it really was not very, I think, responsible of us as a college to keep allowing people practicing in the community where they just had a repetitive failure of exams. So we have now, like many GP colleges internationally and like virtually every other medical specialty college in Australia, have now got a cap on our attempts. So what this means is by 2000, since it starts this term, so the first exams are going to be in next week, in fact. So from that 2019 exams onwards, there's a cap of 3 years, which means that you can sit up to 6 times in those 3 years. You can take 6 months off exams, so you can extend that to 3.5 years. If you do that, you can't sit the exams in that 6 months off, so you still get a possible 6 attempts, but you can do that over 3.5 years should you choose to. The exam cap starts at the moment you sit your first exam. However, there are a lot of people, hundreds of thousands, probably more than 1,000 people who have sat at least one component of the exams but haven't completed their exams yet. So what we've got is a transitional measure. And what this means is that anyone that has failed exams before 2019, they're wiped, they're gone. It's as if you didn't even do them. So they're starting from fresh as of 2019.1 and they get 6 more attempts. However, if you've passed the exams, we're carrying forward those passes for the duration of the pass as per the previous rules. Now that meant a pass lasts 3 years. So if you passed your AKT, for example, the multiple choice question, if you passed that 2 years ago and you only then have 1 more year before that AKT will expire. So it's a pretty good deal really, essentially saying, you know, forget about your failures and we'll carry your passes. So people aren't complaining too much about that. But it's going to get to the pointy end in 2021 where suddenly there are going to be people who are running out of time. And if you don't pass those exams in that time frame, essentially we're saying you can't come back again. So you need to find a new career or a new way of doing general practice, but it won't be through fellowship of the RACGP. The AKT and KFP do remain prerequisites for sitting the OSCE, and the other exam rules as far as eligibility, etc., remain. Right, so moving on. Back to the PEP program, part of the reason that we're putting this program in place is because we want to try and improve the pass rates of those sitting exams that are outside AGPT. Because although we don't publish the pass rates for the different cohorts, it will come as no surprise that those that are not doing the training program and not being supported in learning about general practice in Australia have much lower pass rates of the exams than those that are in a support or training program. So we're trying to balance the inequities to a degree. As I've mentioned earlier, the PEP program is not AGPT. The level of support is much lower, but it's much better than what's been in the past, which has been pretty much nothing. So to be eligible for the PEP intake, for the 2019 intake, you need to be a non-vocational registered GP. You need to have current medical registration. Importantly, you don't require general registration. You can do this program on limited registration, which is different from the AGPT. One of the other differences is that you don't need permanent residency. You can be a temporary resident and come into the PEP program. You do need a job or a job offer in appropriate general practice, and what I mean by appropriate is it needs to be seeing a fairly wide range of ages and genders and types of conditions. So for example, positions like just doing skin cancer medicine is not considered an appropriate position for this particular program, because part of the program is doing a range of activities, practice-based activities and learning units which cover the curriculum of general practice. And if you're not seeing the full range of general practice, then it's going to be very hard to complete the educational component successfully. The other thing that's required at the moment, and this may change in time, but at the moment you are required to have at least a year of general practice, Australian general practice, before you come into this program. Now, that we're in negotiations about that requirement, because in a way it seems a bit silly that to be able to be supported in general practice, you need to already get experience. It's a bit like if you go for a job, and to get the job you need experience, but to get experience you need a job. It's a bit like that. At the moment, because of the funding restrictions and because of the way that the contracts are with the government, is that we do require that year of general practice, but that may change in time. That needs to be done via a GPE assessment, so it's not just, oh, I've done a year and here I go. You actually need a valid assessment done. And there's a bit of a time delay when it comes to putting that assessment in and getting an outcome. So if you're talking to someone that's interested in doing this program, we do recommend getting one of those as soon as you can. The outcome is valid for 3 years, so once they get it done, it'll be valid for 3 years' time. Now, the other little extra bit that is important to know is about the PEP entrance assessment. Now, this is not needed and not valid for those that are going to be coming in and starting the program this time. So those that are already started in the program, although there's those that are going to be coming in from a July intake, and we're going to talk more about that intake in a little bit, they don't require to do and sit the PEP exam. But we are going to be running probably 3 lots of PEP exam this year, and these will be for people that want to enter the program in 2020. So I'll talk more about that in a little bit. In fact, a little bit has come right now. So talk about the entrance exam. So this is going to be run quarterly. This is one of our obligations to the Department of Health as per our contract. We're going to be starting it in April this year. So there's going to be 3 PEP exams this year. That is, if there are sufficient numbers. There may not be sufficient numbers to run the exam, but that's the plan. And then we're going to run 4 next year and thereafter. So the PEP exam is called the PEP EA, standing for the PEP Entrance Assessment. It's somewhat similar to the current selection test for AGPT, which is called the CAT test. Now, the CAT test is a mixture of situational judgment tests, which are been used for a long time in AGPT assessment. They've been part of the environment for a decade or more, and also part of the environment for a decade or more, and also has got applied knowledge items. So the CAT test, the AGPT one, has pretty much knowledge-based, so just to see what your knowledge are. But the entrance exam for PEP is aimed at a slightly higher level than the CAT test. So we're looking at whether or not people can apply that knowledge. So we're looking at AKTs. So similar to the AKT exam, but not at fellowship level, more at entrance level, but looking very much at applied knowledge. So just to give you an example of what that means, a knowledge test might be what are the guidelines, or what medication should you give for someone with hypertension. So what's sort of a purely knowledge-based things, or what's the dose of adrenaline in anaphylaxis? So that's a knowledge test, while a applied knowledge test is having a case where there's a person that has a collapse and they've been stung by a bee, and you have to first of all recognize there's anaphylaxis and then recognize how to treat it. So it's about applying the medical knowledge to a contextual situation that you notice in general practice. So because this program is aimed at those that have done a year of Australian general practice, we are done with the assumed knowledge they should already have a pretty good grounding about how Australian general practice works. So it's coming in with that in mind. However, it's not looking at are you at fellowship level? Are you able to work independently? It's really looking at a very minimum level of competency. So are you safe, but not just safe? Are you a competent enough doctor to be working in general practice? It's really looking at a pass-fail situation. Having said that, we may need to use rankings if the program is oversubscribed. So if there are more people wanting places, then there will be a ranking, and it may also be about location somewhat as well. A little bit like the CAT is used for selection in AGPT, so it determines somewhat where you go and whether you get in. The difference, I think, with PEP is that unlike AGPT, where you're sort of, in a way, you can choose, but in many ways you're sent to a place and you have to find a practice, we're going to try and keep doctors in their current locations as much as we can. So the idea is not that we try and move people from established environments. If they are in a practice and they've been there a long time and they have an established practice base, we want to try and adapt the program so they can continue working in the environment they're working in, with the proviso that it does meet the other requirements of PEP geographically and also at being comprehensive enough in their general practice. So the PEP exam, as I said, is not required for those starting in 2019, but will be coming in for those entering in 2020. So we do have a second intake in 2019, and these they're going to be starting in July. There is going to be up to 200 places, and these are the ones, this is the last cohort who do not require the PEP exam. So if you've got someone that's kind of thinking about it, it's not a bad idea if they want to get in now, because they won't have to sit an exam. They also won't have to pay to sit the exam, like the entrance exam for AGPT. There will be it will be a user pays exam. It's not a it's not a money making exercise, simply a cost recovery. So we're looking at approximately $700 or so to sit the exam. And that's going to be, again, equivalent to what you do for selection for AGPT. So if you've got someone that's thinking about it, doesn't want to sit the exam and would not mind starting in July, let them know that very soon, as in only in a couple of weeks or less, applications will open for the second intake. It will be limited to a maximum of 200 places, and the selection and the application process is relatively short because it's a fairly tight time frame for us to assess applications and then get their initial assessment done, which I'll talk about a bit later about what that involves. So you're hearing it first. This actually hasn't been announced yet about the date. So you are, GPSA, you heard it first here. But further information, including application forms, will be available in the next couple of weeks on the Practice Experience Program webpage. On the last slide, we'll give you this website again, but if you just go to the RACGP website and you type in PEP into the search function, you'll be taken to the website. There's a number of different resources, including the applicant guide. There's also information in a Q&A format and some general further information about the program. Just a quick word that I haven't yet mentioned about the PEP program, and that's about sitting exams. So unlike the AGPT program, in which you are able to sit exams while on the program after you have completed 2 years on the program, so that usually is your hospital time as well as your GPT-1 and GPT-2 terms. So when you're in GPT-3 and extended skills, you're able to sit your exams. The PEP program is different. The PEP program, you are not able to sit your exams while you're on the program. So it's really just a hiatus from your exam sitting capacity. That's got pros and cons. One of the big pros, now we're looking at exam capping. It means that if you join the PEP program, your exam candidature is suspended.
Questions. I don't have anything to add to what you've presented, but I can see from some of the questions that the issue of 3GA provider numbers that have been issued by the RACGP has come up a few times, as well as just some of the complexities around individual cases of individual doctors that are in the program or have to make certain decisions about whether they sit the exam and more importantly to have their provider number extended. So there's a few issues flying around, but they're the main ones.
Completely stops when you're on PEP. On the other side, you can't actually sit exams while PEP, but it just gives people a chance to have a breather, to study, to get prepared, and then once they come off PEP, their clock will restart and they can sit exams again. But for those that are halfway through the exam process, it certainly is a decision which has to be made on an individual basis. Is it right to keep ploughing on and keep giving the attempt, or is it something that really should take a bit of a step back, regroup, sometimes just have a bit of a break? Sitting exams again and again and again can be incredibly draining on one's physical, emotional and social health. So sometimes having a bit of a break from the exam process can be useful. But that's where it comes to the exam situations. As far as the Medical Board and Department of Health, they are very supportive of this program. So if people are running out of registration time or running out of provider numbers, during the PEP program, things are still getting ironed out. But we've had an in-principle agreement from the Medical Board and the PEP and the Department of Health that they will support doctors continuing if they want to re-register or re-continue as long as they are actively engaged in the PEP program. So there are of course individual exceptions, and we can't make any blanket rule, and that's for each individual doctor to negotiate with either Department of Health or the APRA, depending on their situation, whether it's a registration or a medical provider number issue, Medicare provider number issue. But we are trying to work, all three organisations are trying to work together to try and give this very vulnerable group the best possible chance of getting through these hurdle assessments. I did see a question that popped up about the specialist pathway and PEP. So I just want to quickly address that now because that's not actually part of the next part of this program. So for specialist doctors, so just for those that are unaware, we have every college in Australia has a specialist recognition pathway. So essentially it's those, the APRA or the Medical Board term for that is a competent authority pathway, and it's for those that already come in with specialist qualifications. So in our case, it's specialist qualifications in general practice. Now, the specialist recognition pathway changed last year as far as the requirements go and how they're assessed, and this was nothing to do with the PEP program, all to do with Medical Board requirements, which actually started way back in 2014. So essentially now that we have divided them into three categories, that's substantially comparable, which were the old FAEG or Cat 1 doctors, and then there's partially comparable and not comparable. Now the partially comparable and the non-comparable can definitely join PEP, that's not a problem, they join like anyone else joins. For the substantially comparable group, currently, they're not part of PEP. We're developing a special pathway for them, which are sort of a variation on PEP, should I say, which will be a 6-month program. So that hopefully will be up and running by July, but not. It's going to be a slightly different process, different entry process. So they won't. Anyone that's in that category won't be joining through the normal mechanisms, and it's a bit of a watch this space. But certainly we will be adapting the practice experience program to help and support all doctors who are coming to work in Australian general practice. Okay, so moving on to the big elephant in the room, Medicare provider numbers. So just to give you a bit of an overview, with the 3GA status, which the college got in January, that comes with it the ability to issue provider numbers. Now, we don't directly issue provider numbers, at least not at this stage. They're still issued by the Department of Health, but we're working in a partnership with the Department of Health to try and have applications that will be initially processed by us. So we do the initial paperwork and then they get sent to the Department of Health. The decision about whether or not a provider number is issued under this program is at the moment under the Department of Health's say. So they're the ones that actually make the final decision about whether or not they'll issue a provider number or not. So they have released a couple of weeks ago some program guidelines about what they will and won't issue provider numbers for. And I've given you the link on the slide there. So it's a bit complicated, but if you're interested in trying to work out how this program is going to work, feel free to have a look at those guidelines. They're publicly available. But some general principles around this. The first of all, as I mentioned earlier, is this comes under the stronger rural health strategy. So this is a rural program, which means that most participants will need to work in MM2 to 7. There are going to be limited places available in Modified Monash 1, so that's the metropolitan areas, but they'll be strictly capped. And we're still negotiating with the government about who exactly is going to be able to go in those places. It is likely, although this is yet to be finalised, that the people that will be in MM1 are those that are already in MM1, so those that are established in MM1 already, people that already have workforce program eligible provider numbers in MM1, so they're already working under the SAPS program or the after hours deputising service program, so they're already working in MM1 and established in that area. And the other group that may be getting status in MM1 are those that are entering through a specialist pathway, but that's yet to be finalised. There will always be a group of exceptional circumstance provisions, so if there is severe illness or other exceptional circumstances, there will be provisions for a change of location. But for the most part, particularly those that are entering in future intakes, the expectations will be that you'll be in daytime practice in comprehensive general practice in an MM2 to 7. If people are working in after hours and they want to continue to work in hours, they're welcome to do so. But the general expectation is that if you're wanting an MM1 provider number, you'll need to get your provider number from another source, but you're still welcome to do the PEP program. So if you're eligible for another program, such as the medical deputising, etc., you can continue on that program if you're already on that program, getting the provider number from that source and do the PEP educational commitments. But if you want a PEP provider number, the majority, not everyone, the majority are going to be, in future at least, needing to be in MM2 to 7. The other important thing to note is about the restrictions when it comes to DWS, which is the District of Workforce Shortage. So anyone that's under the moratorium, so the 10-year moratorium, which is shortened for some doctors depending on how rural or remote that they're working, but anyone under that Section 19AB requirement will still have to fulfill the District of Workforce Shortage requirement. So it means that you can't just work anywhere in MM2 to 7. There are lots of Monash 2 to 7 areas, well, particularly 2 and 3, that aren't District of Workforce Shortage. I live and work in one of those myself in beautiful Ballina in northern New South Wales. So we're an MM2, but we're not District of Workforce Shortage. So a PEP participant who was under Section 19AB would not be able to get a provider number in my area. But if they weren't under 19AB, if they were Australian graduates or they'd already fulfilled their moratorium requirements, they would be eligible for a number under in the MM2 region. So there's most likely going to be some extra provider number questions that we can get to in due course, but I'm going to move now on to the structure of what this PEP program actually is. So as mentioned earlier, there is a very strong emphasis on self-directed learning. This is not a spoon-feeding type program. We do an initial core skills analysis, also known as the ICSA, and this is a combination of multiple choice questions, some self-reflection activities, and looking at a range of different skills and curriculum areas and assessing about your level of knowledge and skills on those various areas. Application form looking at the type of practice that you're working in, level of support, etc. And then we do some video consultations. So essentially what this is we get you to analyze some video consultations and write your ideas about what those, what the pros and cons, the good and the bad of these consultations, these simulated consultations. So that's what the ICSA is. So that's 3 parts of this, and people are needing to complete all 3 parts before we can offer them a place on the PEP program. Based on the results of that ICSA, and the length of program is determined, and also what modules are required. So I'm going to talk a little bit about that in a slide or 2. So it's an individualized process, and the program, I should say, and it involves some mentoring, structured mentoring, learning units, which are online education activities and support program, and also a workplace-based assessment, which includes at least 1 clinical visit in most cases, where someone will come out to the practice and actually assess the doctor. So just unpacking that a little bit more, this program is being delivered by the RTOs. So the RTOs are going to be doing the delivery arm of this program. So while the RACGP are the ones that assess the learning units, so I'll just go back to these learning units. So we'll basically say, look, there'll be this number of mandatory units, this number of recommended units, and so there's sort of there's basically core units and then recommended units. And mandatory units. So the mandatory units are ones done by everyone. The core units are the ones that we feel that based on your ICSA assessment, we feel are really important you should do. And the recommended units are ones we think are a great idea, but you can pick and choose within those. So we kind of get that structure, which is done as an individualized process. We get all that sorted. We have an online portal where all that information is loaded, and then we hand over to the RTOs. So the RTOs provide an educational mentor that essentially helps the participant go through the learning units. They keep an eye on things and provide some support. It's very limited because of the funding is so limited. So this is not a where they're going to be able to have instant and everlasting large amounts of access to a mentor anytime, day or night. It's not like that. There are only limited funds available for contact, but the RTOs are doing the very best they can with the funding they're given, which is not much compared with what you get for AGPT. The other things the RTOs will be doing is the workplace-based assessment component. So there'll be RTO assessors that are employed by the RTOs to do a combination of direct observation. This may be in practice observation, or it may be in a workshop setting. So it may be that participants will come and do simulated or OSCE type cases and get some feedback on their performance. So there's likely to be a combination of different approaches depending on the RTO and the geographical location of the participants. So it'll be a mixture of different, but the people will be observed actually consulting, whether that be simulated or in real life or both. It will also involve clinical case analysis, and this may be a random case analysis if someone goes into the practice and looks at a series of records. It may be that the participant will prepare a case that they've seen, and then using a clinical reasoning approach, talk through that case and get some feedback and education that way. The other component is a multi-source feedback, so they're going to be required to get feedback from their patients, people they work for, etc., in a structured multi-source feedback format. And again, their learning units will be reviewed by RTO mentors. I just see there was a question from Jan about videos of consulting. Yes, so you can absolutely do consultation by video. The only issue with that is that in some states and territories, particularly Victoria and New South Wales, there are some issues with video and consultations and the way that the Privacy Act and health records are monitored and required. That practices that do video consultations, even for educational purposes, need to retain it as part of the medical record. So there are some issues medico-legally when it comes to video consultations. But Jan, I know that you are in Northern Territory and Queensland, in which you work. It's all free for all as far as I'm aware, so not a problem in that. So my only just suggestion is if RTOs are looking at doing that, they just check their state-based legislation and talk to their medical defence organisation before doing that. Yeah. So Jan just mentioned that the interesting, as far as the telehealth. So Jan, just to let you know, the telehealth, it's not a problem if you don't record it. So if it's a live thing, like a live Skype thing where there's no recording, that's not a problem. But as soon as something is recorded, so if you're recording consultations as part of even just an education process, certainly in Victoria and likely in New South Wales, there's been a ruling by the Health Commissioner in Victoria which makes it very, very clear that any recording, even for educational or assessment purposes, needs to be part of the medical record, which becomes problematic because if you think about how much data that takes, and then it has to be part of your backup, has to be kept for 7 years and or more if it's a child, or actually it's more than 7 years because it's from the 7 years from the last time you saw the patient. So it ends up being quite quite an imposition on practices if you are recording information in those states. But Queensland, touch wood, have yet to adopt that kind of because we don't really want to know the answer. One of the problems was that not the problems, but the Victorian Health Commissioner was directly asked, and so made a ruling. And now the ruling's made. It's it's very hard to unmake. So we're just hoping that the other states fly a little bit under the radar.
Nothing else.
Okay, so moving along to the last part of our webinar, and that's about the role of supervisors in the PEP program. So unlike AGPT, where there is a very heavy emphasis on supervisors and supervision within the practice and the apprenticeship model, the PEP program doesn't involve a mandatory supervisory component unless the participant is already under supervision requirements as opposed that are imposed by APRA. So those are those that are on limited registration. So essentially it's a continuation of their registration, supervision requirement under registration, rather than any imposition or added supervision requirement as per PEP. Having said that, we highly recommend that the PEP participants seek support. They seek the help and support of experienced GPs, preferably in their practice and or in their community. So we're highly encouraging people to seek out their own mentoring and supervision side of things, but it's not actually a part of the PEP program. There is a difference between mentorship and supervision. So as a supervisor, you do have a medical legal responsibility as far as providing clinical advice to someone. If you're mentoring someone educationally and you're not providing specific clinical advice on cases, that doesn't have the same medical legal responsibilities as being an assigned supervisor. So if you are wanting to mentor and support someone, it's just worthwhile just being very open and transparent and discussing what your role is. Are you going to take on the role of a clinical supervisor and then therefore share the liability somewhat as far as clinical decision making going, or are you there as a support person to help them study and help them acclimatise and get used to general practice? So different roles, and it's good to make sure that the expectations of both parties are made very clear at the outset of your relationship. So we talked about this a little bit already, but I just want to highlight the differences between the PEP and the AGPT program. So there are different eligibility requirements and they're targeted at different groups. The AGPT is fully funded and funded much more generously than the PEP program. The AGPT requires a hospital year. The PEP program does not require a hospital year. PEP is a support program. It's not a training program. It's more individualized, it's more learning driven, and as we mentioned earlier, it doesn't allow you to sit exams while you're on the program, while AGPT does. So you may be asking yourself, why would someone choose the PEP program over AGPT program? Surely having a program in which is much more money, much more support, surely that's something that's preferable. Well, it depends on who you are. So some people are not eligible for AGPT, so those that have got temporary residency or on limited medical registration, limited registration by AHPRA, they can't join AGPT, they're not allowed to. The other group is people that have been working for a long time in general practice already, or have come to Australia and not done the kind of hospital experiences required for AGPT. So AGPT require you to do a hospital year either on the program or before you join, and that then gets accredited through a recognition of prior learning process, an RPL process. So some people don't have that experience and don't want to go back to hospitals, or are not able to get job in hospitals doing sort of resident hospital type terms. The other thing is that the AGPT requires people to work, for the most part, depending, unless there are exceptional circumstances, in 2 different practices at least during training. So they have to move practices, and a lot of people don't want to do that. They may not want to work in an accredited practice. Accredited training practices are not available everywhere, and they're not suitable for everyone. So that may be a practice owner, or maybe working as a solo GP, or maybe just don't really want to work in a training practice. They may have their own setup and they don't want to leave where they're working. So we really are, a lot of this program is trying to support doctors in the environments they already are in, the environments they're set up in, and trying to give them support where they are, rather than AGPT, which picks them up where they're in and plonks them in somewhere else, and has a lot more stringent rules when it comes to working hours, supervision, workshops, releases, all that kind of stuff, which suits a lot of people, but also doesn't suit a lot of people. And so PEP may be more suitable for that cohort. So it's got a lot more autonomy, it's got a lot more flexibility. And the other group are those that have already completed AGPT and were unsuccessful in their exams. Then PEP at this stage, although that may change in the future, but for the time being, PEP is eligible for them. So those that have run out of AGPT time are able to join the PEP program, get hooked in with their RTO again, and have some support as they're moving through to do their fellowship exams. So that finishes the formal part of the webinar, and we're running very nicely to time. So I've just got a few resources that I mentioned, or 2 particular resources that I mentioned earlier in the website. If you didn't get it, in the webinar, if you didn't have an opportunity to write those down, then feel free to do now, or to do a screenshot. And I'm just going to have the last few minutes to go back to Gilbert to see if there are any questions that he'd like me to address, or he'd like to make any mentions. That's great. Someone just mentioned that the Doctor Connect link doesn't work. It was It was available on that link as of last week, so maybe that has changed. We'll have to look into that and send around the correct number address if that has changed. I'll just having a quick look myself. Yeah, no, it does link. It's working for me. So essentially it comes under the if you go onto that page and you look at the non-vocationally registered support program, and there is information on it there. And I'm just trying to find where the actual guidelines are. They have moved it around since I've last looked at this page. Oh, here it is. So it comes under the fellowship program structure. So if you go to the fellowship program structure, and it comes under the RACGP Fellowship Program Placement Guidelines, which is a link found on that page. So it's a little bit hard to find, but it's not a nice, happy, easy read. It's not very difficult. It's looking at broad principles about the program, but particularly if you have questions about the provider number status and essentially how it all works, then that's the guide that the Department of Health have put out to answer the broad questions. But
Okay, fantastic. Genevieve, thank you very much, and Gilbert, for your time this evening. I think there will be time for people to continue to ask questions, but also anything that hasn't been answered, we will make sure that there's a response that comes out with the frequently asked questions, as we normally do with all of our webinars. Your feedback is important to us, so we would like to understand if there's something that we could do better with these webinars. We'd like to acknowledge the support and by funding from the Australian Government and the Australian General Practice Training Program. We'd also like to thank the RACGP for their in-kind support in providing the presenters for this webinar. It is their program, it is important to all of you, so thank you very much, Genevieve and Gilbert. It's a really wonderful resource to have you available to all of the members. We've sent you through the evaluation feedback into your inbox. That is sitting there now. We'd love to hear that. We will make sure that that feedback is received by the presenters tonight. Thank you very, very much for attending, and we look forward to attending in the future.